calf.
Okay.
First of all, knee joint corresponds to the knee region. What are the borders? Superior border of the knee region, you have already known. It is circular line going in 6 centimeters upwards the patella. Lower border, it is the circular line going in to tuberositas tibia. Between these circular lines there is knee region, which knee joint corresponds to. Below the circular line going through the tuberositas tibia. What is the type of the joint? It is hinge joint. That's why it is limited in movement. It has limited movement. What bones does it consist with? Consists with 3 bones. They are femur, tibia, and patella. Fibula we exclude from the joint. Patella is the greatest sesamoid bone in our body, which serves as the rest for knee joint. Without patella, our knee joint might be able for hyperextension. So, what is hyperextension? Patella serves as rest and prevents hyperextension. It is faced upwards with its base and downwards with its top. If we look at the articulation surfaces, we will watch that they are not symmetrical. They are different. What makes them symmetrical? What adopts them to each another? They are meniscus. 2 hyaline cartilages which line tibia and adopt it for femur. We have 2 meniscus, lateral and medial. The lateral and medial meniscus come from hyaline cartilage. Well, students, what pathology do meniscus tie with? With traumas. Who mainly have such traumas? Sportsmen. Well, especially football players. Really, students, knee joint very often endures trauma, endures different traumas. Well, the mechanism of the trauma is the next. Football player stays on his one leg, and at the moment he rotates for pushing the ball. So, medial meniscus endures the whole weight of the body, and in turning it is crushed between femur and tibia. At the moment both surfaces become not symmetrical, so extremity is usually blocked in first position and sportsmen feel severe pain. doctors inject Novocaine inside the knee joint to return it in normal position. If meniscus is destroyed badly, surgeons perform resection of it. The operation is difficult. First of all, because of aseptic area of the joint. The next problem, hyoid cartilage regenerates, but after regeneration, there are doubts it will be so comfortable as the previous. Will patient return to the sport again or not?
Maybe.
Maybe. Yes, maybe not. So it is the problem after trauma. I agree. Well, students, what are the ligaments? Again, we differ internal and external ligaments of the articulation. First of all, internal ligament which ties anterior poles of both meniscus is named ligamentum transversum genum. It is internal. What does it do? It stretches meniscus during walking. Stretch meniscus during walking makes them more comfortable for joining surfaces. Students, on the tibia we choose eminentia intercondylaris. Do you see it? Eminentia intercondylaris. Another two internal ligaments, ligamentum cruciatum, insert anteriorly and posteriorly from eminentia intercondylaris. In front and backwards of eminentia intercondylaris. For example, anterior cruciate ligament begins from the lateral condylus and turns in front of eminentia intercondylaris. Posterior cruciate ligament begins from middle condylus of femur and turns backwards from the eminentia intercondylaris. In such way, cruciate ligaments tie femur and tibia. Once more. The eminentia intercondylaris anterior and posterior tie femur and tibia. Here they are. They tie both bones together.
Teacher, can you please repeat for anterior ligamentum cruciatum? Where does it begin from?
I'm not going to ask you about insertion.
But we want to know.
Oh, for general education, I mean.
Yes.
Only for general education. Well, students, the anterior cruciate ligament begins from lateral condylus and inserts in front of eminentia intercondylaris. And the posterior cruciate ligament begins from medial condylus turns to the posteriorly from eminentia intercondylaris. Again, cruciate ligaments may be destroyed, may be affected in sportsmen. How do doctors differ their traumas? The clinical, the symptoms in examination is named symptom of drawer. Symptom of drawer. It may be anterior. Drawer may be anterior and posterior, according of ligament. Symptom of drawer. We are showing it for you. For example, the patient sits down and doctor tries to pull tibia forward. If he is able, what it is? It is not normally. The drawer is anterior. Because anterior cruciate ligament is affected. If it is possible to displace tibia backwards, the drawer is posterior, because trauma of posterior cruciate ligament. Did you say?
Kalau bukan anterior, kalau tarik belakang.
Normally, tibia is not displaced.
At all.
It is tied firmly.
One and also do.
You will feel these displacements really. The ligaments are internal too. Well, another internal ligament is named meniscus femoralis. Ligamentum meniscus femoralis. Meniscus femoralis. It's internal. Internal. It is also internal. Is stretched between lateral meniscus and posterior cruciate ligament. Here it is. Do you see ligamentum femoral?
Posterior meniscus.
Поплит, как я сказала? Between lateral meniscus and posterior cruciate ligament. Meniscus femoralis. It is congeles of femur, femora, and meniscus. Well, students, what are the external ligaments? We are discussing external ligaments. First of all, it is ligamentum patella propria, which comes from tendon of quadriceps muscle. Tendon of quadriceps femoris performs ligamentum patella propria and inserts to tuberositas tibia. Ligamentum patella propria. Due to it, patella occupies its permanent position and doesn't displace anywhere, and serves for us as a reliable rest. But in a case of trauma, the ligamentum popliteal propria, patella displaces aside. That's why knee joint becomes unstable and limping appears. Limping is the common sign in traumas of any ligament of the knee joint. Do you understand what does it mean, limping? Well, students, inside there are two external ligaments which are named ligamentum collaterale. Laterale и mediale. Collaterale, laterale и mediale. And mediale. Well, students, we may consider knee joint as articulation between patella and two long levels, such as femur and tibia. Levels perform the straightened longitudinal axis. Don't they? Yes. But in the case of fracture, any collateral ligament, pathological deviation of tibia appears. Tibia displaces pathologically medially. In the case of fracture, collateral lateral ligament, or the deviation may be lateral if medial collateral ligament is affected. According logic. Are you agree? That's why examining patient, doctor checks their longitudinal axis, between femur and tibia, certainly. Reassure that collateral ligaments are intact. Students, in back there is ligamentum popliteum. Backwards of the joint there is another external ligament which has a Greek passage, ligamentum popliteum. Do you see that? Ligamentum popliteum, because it is situated in popliteal fossa. Popliteum, да. Well, students. Да. Under external ligament, imagine for yourself, please. We have the capsule of knee joint under the external ligament. It covers the whole articulation. Well, but each capsule of the joint consists from two layers, fibrous layer and synovial layer. Fibrous layer has ordinary, simple passage without any peculiarities. On contrary, synovial layer has many recesses, pouches, where pathological fluid may be condensate. It is difficulty to puncture it out. Well, students, what does synovial membrane produce? Synovial fluid to make our movement smoothly. And mainly scientists choose 9 main synovial recesses. 9 main synovial recesses. All recesses may be described with the words anterior, posterior, superior, inferior, lateral, and medial. Please look after. Not necessary. Students, the main recess is named recessus synovialis anterior, superior, medianus. Is joined to the patella, and mainly it is punctured. Recessus synovialis anterior, superior, medianus. Synovialis anterior, superior, medianus. Joined to patella. That's why it is punctured, because puncture is performed around patella. Easy. Well, it gets into two, recessus synovialis anterior, superior, lateralis, medialis. Imagine for yourself.
Just imagine.
Gets into two, the beginning is the same. Recessus synovialis anterior, superior, lateralis, medialis. From contrary side.
Sebelah sana.
Didn't catch. It didn't need. Recessus synovialis anterior superior medianus. Recessus superior anterior superior medialis et lateralis have got 3. Inferiorly in front there are 2. Recessus synovialis anterior inferior lateralis medialis.
Anterior inferior.
Anterior inferior lateralis medialis have got 5.
5.
Да, backwards there are 4. Recessus synovialis posterior superior lateralis medialis. Да? И posterior inferior lateralis medialis. Are you agree? In such way? Lateralis medialis и posterior inferior lateralis medialis. Is it clear? Of course, all these recesses communicate with each other. That communicate. Though in edema, after traumas, the synovial recesses become isolated. Condensate pathological fluid, I mean blood or pus, easy, and result in adhesion. That's why it is necessary to puncture the knee joint in time. Puncture is performed around patella. Students, if you understand me, guess this. Why this knee joint has so strange appreciate? What layer is missed? Fibrous layer of the capsule. I think you understand me. Is it clear? Because of missing fibrous layer of capsule, the knee joint has so strange appreciate. Students, here, each joint has synovial bursas. They mean isolated synovial formations, isolated synovial formations, bursa synovialis, another than synovial recesses. They are isolated. They are situated under skin, under fascia, under the tendon, and they make contraction of different anatomical layers smoothly. Do you understand? They make contraction of different anatomical layers smoothly. Skin above fascia above tendon above capsule. We don't study them because their location is different. Their numbers are different too. But keep in your mind that in a case of inflammation, the unpalpable synovial bursas become palpable and painful because of edema. So if after trauma you palpate any isolated and painful formation in knee joint, be sure it is a synovial bursa. Diagnosis is bursitis. Is treated with antibiotics, physiotherapy, покой. Rest. Sometimes the synovial bursas are punctured, and then bind it tightly to prevent transudation, to decrease transudation. We have finished the medium. Yeah, have finished the medium. The next question is the calf or shin. Shin. Students, the upper border of the shin we know, the circular line going through the tuberosities tibia. The lower border of the shin goes through the bases of both ankles. Through the bases of the ankles.
Okay.
Shin has peculiarities. For example, it contains two bones, tibia and fibula. Tibia has a sharp anterior edge, which is certainly palpable. Middle aspect of tibia is not covered with muscles at all. Middle aspect of tibia is out of the muscles. That's why traumas of it are very painful. And fighters know about this fact very well. Каратисты, they have the way of protection. They push the shin of the opponent with the foot in such way irritate the periosteum of tibia. Do you understand? Periosteum is innervated the best. So this way of protection is very painful. Well, students, and again we study the region due to cross section of the shin. The intersection of the calf is middle third. Fascia covers the middle aspect of tibia is not covered with muscles at all. I consider the calf very ugly. Так. Own fascia gives off two sectors performing three asymmetrical facial compartments. Posteriorly, the compartment is for flexors. Posterior is for flexors. The lateral is for pronators. And anterior aspect has extensors and supinators.
Posterior for what?
For flexors of the foot. Flexors of the foot. Anteriorly, extensors and supinators in combined. Let's feel them. Anteriorly, there are two muscles, musculus tibialis anterior, is extensor and supinator. Superficially, there is musculus extensor digitorum longus. Under it is musculus extensor digitorum longus, extensor hallucis longus. Backwards, we choose superficial and deep flexors. Superficially, there are three muscles. Two heads of the gastrocnemius muscle, the musculus gastrocnemius, under them there is musculus soleus. These three muscles inoculate with each another very often, forming triceps surae. Triceps surae means inoculation of three muscles, two gastrocnemius, lateralus and soleus. By the way, their tendons inoculate very often too, forming a heel tendon. Who was the heel?
Achilles.
Greek hero. Who mother held by heel, putting in fairy river, and protected him the heel, tied with a heel tendon and with heel bone. For all generations. We choose deep flexors. Keep in your mind that deep flexors are antagonists for extensors. For example, quite right on membrane we have musculus tibialis posterior. Tibialis posterior. Inside there are laterally musculus flexor hallucis longus. Hallucis means big toe. And medially big toe is musculus flexor digitorum longus. Don't surprise that the muscles are situated in not logical order, because just under middle third they will cross and stand and stay in logic. The flexor hallucis longus medially, flexor digitorum stays laterally. Students, between two flexors, deep and superficial, there is canal, which ties popliteal fossa and crus. So it is named canalis crura popliteus. Is it clear? Crura popliteus, because it ties crus with popliteal fossa. Crura popliteus. Laterally, there are two muscles, musculus pyranneus longus et brevis. Musculus pyranneus longus et brevis. They are pronatals for the foot. They pronate foot out. Students, what are the vessels and nerves? First of all, what does arteria popliteal divide in? Intertibialis и anterior и posterior. Хорошо. Here they are arteria tibialis anterior и posterior. The way are the same. Vena tibialis anterior и vena tibialis posterior. Posteriorly there is canal. Tibialis posterior и anterior. What does nervus ischiadicus divide into? Nervus ischiadicus. What does? tibialis, which stays in the canalis cruropopliteus, another ramus is nervus peroneus communis. Firstly, it stays in lateral compartment, then divides into nervus peroneus communis, и nervus peroneus superficialis, и nervus peroneus profundus. Profundus pierces the frontal septa and gets anterior compartment. Let's sign the vessels and nerves. Arteria vena tibialis anterior. Nerve is peroneus какой? Profundus. In the canal there are arteria vena tibialis posterior, nervus simply tibialis.
Nervus tibialis.
Laterally is nervus peroneus
superficialis.
Молодцы. Superficialis. And don't forget about the subskin vein in the calf. It is vena saphena parva. Is undergone tuberculosis disease very often, it gets vena tibialis or vena poplita. The pathological position of foot in case of traumas, the nerves in the calf.
Foot?
The pathological position of foot in case of traumas of nerves in the calf. First of all, students, nervus tibialis, if it is injured, what muscles does it innervate? Flexors in common, That's why in a case of its trauma, extensors dominate. So, the foot is extended. Extended foot is named as heel foot. Heel foot. Really, patient bases on heel in walking. He doesn't feel much disturbances because in norma we base on heel too. But top of the foot is elevated. Then, if nervus tibialis anterior or nervus peroneus profundus is injured, what it will be? Flexors dominate. Flexors dominate. Foot hangs, forming